Good evening. Tonight I'm going to talk about coronary stent thrombosis. I have 20 minutes to do that. And as Dr. Mahmoud said, next time it will going to be cases about stent thrombosis. Our talk tonight will be mainly about durable drug-eluting stents with a durable polymer, which are all the studies are mainly about durable polymer drug-eluting stents. Brief introduction: percutaneous coronary intervention, which was pioneered by Grunzing in 1977, has become the most frequently performed therapeutic procedure in medicine. The use of balloon angioplasty, which was limited by abrupt vessel closure owing to dissections and restenosis, prompted the development of stents to maintain lumen integrity. The first stent was placed in 1986 by Jake Poole and Arsch Sigwart in Zurich. They introduced metallic coronary stents into clinical practice to overcome the key limitations of balloon angioplasties, which I've alluded before, of course, elastic recoil. Bare metal stents addressed one of the key limitations of balloon angioplasty by reducing the risk of abrupt vessel closure resulting from local dissections. Coronary stents improved procedural safety and efficacy and eliminated the need for surgical standby. However, stent-mediated arterial injury elicited neointimal hyperplasia, leading to restenosis and the need for repeat revascularization in up to 1/3 of patients. Drug-eluting stents emerged in the early 2000s and were rapidly embraced due to substantially improved anti-restenotic efficacy of these devices as compared to BMS. For continue, this is a figure of this. The first one is the DS with durable polymer coatings. We can see the stent rods and the polymer will stay. The second one, DS with biodegradable polymer coatings. And now there is the stents with polymer-free drug-eluting stents. Because my main reference will be the US. As I said, the main talk will be about DS with durable polymer coatings. And usually the biodegradable polymer coatings, they biodegrade in 3 to 4 months. Drug-eluting stents, this is a brief about introduction about drug-eluting stents, have 3 components, as we all know: a metallic stent platform, polymer coating, and anti-proliferative agent. Stent platforms. Available platforms, first generation were mainly stainless steel, and then they introduced cobalt chrome or platinum chrome. Cobalt chrome alloys provide improved radial strength and increased radio opacity as compared with stainless steel, allowing for engineering of thinner struts with greater deliverability. And this is the main point, thinner struts, this is the main point for that reduce the incidence of coronary stent thrombosis in the second generation drug-eluting stents compared to first generation drug-eluting stents. So, platforms made with thinner struts, which may result in less arterial injury and reduce the risk of restenosis with lower thrombogenicity. What differs platinum to chromium alloys are used in an effort to further improve radial strength and conformability. The polymer coatings that are applied to the stent surface serve as drug carriers and permit controlled drug release. The progress in polymer technology has been aimed at decreasing local inflammatory reactions and thrombosis by improving the biocompatibility of polymers. We'll come to that in a bit, about the inflammation. Anti-proliferative agents that are used for the platforms of drug-eluting stents are highly lipophilic molecules that are distributed into the arterial wall and exert either immunosuppressive effects, sirolimus, which are the inhibitors of mammalian target of rapamycin, or anti-proliferative effects, paclitaxel, on the smooth muscles. This is an example, or this is a figure of the bare metal stents to the left. We can see that the main function of the drug-eluting stents, the anti-proliferative agents with the paclitaxel, sirolimus, everolimus, sirolimus, They are inhibition of neonatal hyperplasia due to the bare metal stents. Okay, so we can see the difference, of course, the difference between bare metal stents and drug-eluting stents. It's not that obvious, but this is a table of the stents that are approved in the US. We can see that, of course, Cypher, in the last table, Cypher, Taxis, Ion. Endeavor, Promise, they are no longer available in the US. Okay? The main stents available that they use are the durable polymer drug-eluting stents, or mainly Zions, Promise Element, Promise Premier, and Resolute. And there is one biodegradable polymer, which is Synergy. This is biodegradable polymer drug-eluting stent. There's only one stent. Of course, now the bioabsorbable scaffold, now for example, they have stopped making it, or the use has been reduced a lot back in September when they had incidents of increased complications. We can see here, this is an old table. We can see the difference between the first generation stents. This is the Taxis, the paclitaxel, Taxis Express, Taxis Liberté, the Sirolimus, which is Cypher, they are no longer used compared to the second generation stents. We can see the main thing, look at the stent thrust. For example, Cypher was 140, the stent struts. Paclitaxel was 132, then reduced to 97, compared to 81 in all the second generation stents. And this is, I alluded before, this was the main thing that decreased the incidence of stent thrombosis, thinner stent thrusts, and the newer technology in the polymer coating. We can see here a table comparing the bare metal stents, first generation drug-eluting stents and second generation drug-eluting stents in all goals: death, myocardial infarction, TLR, target lesion revascularization, and definitive stent thrombosis. We can see that the drug-eluting stents, second generation in the blue, that they much better than the second generation stents. Okay, we still have a problem, because sometimes what happens in arterial healing after stent implantation? While providing inhibition of intimal hyperplasia, DES should permit physiological arterial healing with smooth and homogeneous endothelial coverage of stent struts. This may be balanced by an excessive anti-proliferative effect and persistence of stent components, example polymer coating, leading to chronic inflammation and impaired arterial healing with the attendant risk of thrombotic events. This was the main thing. I remember I was a fellow, I can't remember first year or second year. In the past, when we used to be a resident or a first fellow, after Taxis stents, we used to give dual antiplatelet therapy for 6 months. After Cypher stent, we used to give it for 3 months. Then reports of late stent thrombosis came out in 2006 in the ESC, European Society of Cardiology. And I remember I was there, as I said, I was a fellow there, and that drug-eluting stents was all over the news that they are not safe. ABC News, NBC, CBS. It was like putting a drug-eluting stent, it's a crime. This changed the duration of dual antiplatelet therapy to 12 months. This was the main thing that led to longer duration of antiplatelet therapy. For example, this is an example of excessive neonatal hyperplasia after a stent placement in A. B, delayed arterial healing, and C is a physiological arterial healing, a normal stent, perfectly placed with no problems. As I said, DES with controlled local release of antiproliferative agents have consistently reduced the risk of repeat revascularizations as compared with bare metal stents. As I said, however, a number of reports presented at the ESC in 2006 questioned the long-term safety of drug-eluting stents, leading to a reduction in their use, along with intense review by regulatory agencies and recommendations to extend dual antiplatelet therapy for at least 12 months. Back then, we changed our practice that longer duration of dual antiplatelet therapy. With all the newer technology of drug-eluting stents, with all the better polymer, better deliverability, we face stent thrombosis, the biggest fear of every interventional cardiologist, stent thrombosis. which is a rare but serious complication of treatment with both BMS and DS, has been related to procedure factors and inadequate platelet inhibition during the early post-implantation period, as well as chronic inflammation and delayed arterial healing during late follow-up. According to the ARC, the Academic Research Consortium, we divide stent thrombosis can occur time-wise, acutely within 24 hours, subacutely within 30 days, as late as 1 year called late thrombosis, or more very late after stent thrombosis. So acutely within 24 hours, subacutely within 30 days, as late as 1 year late, more very late after stent placement. The ARC classification of stent thrombosis, they classify it in definite, probable, possible, and sometimes modified possible. Probable, the patient had acute coronary syndrome with angiographic or pathological confirmation of thrombus. Probable, unexplained death within 30 days, or MI involving target vessel territory without angiographic confirmation. Possible, any unexplained death beyond 30 days. They modified it, any unexplained death beyond 30 days where sudden death or acute ischemic event is like. Okay? So definite, probable, possible are the ARC, Academic Research Consortium for classification of stent thrombosis. There is one classification that are not present in the ARC, which is called intra-procedural stent thrombosis. Is the development of occlusive or non-occlusive new or increasing thrombus in or adjacent to a recently implanted stent before the PCI procedure is completed. Okay? I'm sure many of us have seen that. We talked about the stent thrombosis, how do you classify them time-wise, the ARC classification. Now the mechanisms. Risk factors for the development of stent thrombosis fall into broad categories of procedural, patient, lesion, and stent characteristics, as well as the cessation of antiplatelet therapy. Each risk factor is likely to predispose the patient to stent thrombosis, which is characterized by platelet activation and aggregation by one or more of the following mechanisms. So, stent thrombosis lies into one of the three mechanisms outlined here. Persistent slow coronary flow, local or arterial, as occurs with dissection or hypoperfusion. Anytime we finish a procedure, ACS with TIMI-FLO 2, usually it's not as good as TIMI-FLO 3, of course. Prior to re-endothelialization, exposure of the blood to pro-thrombotic subendothelial constituents, such as tissue factor or the stent itself. Failure to suppress platelet adhesion aggregation at the time of pro-thrombotic risk, as occurs with premature cessation of antiplatelet therapy or drug resistance. So the mechanisms of risk factors, as I said, of mechanism of stent thrombosis, they lie into one or more of the following mechanisms. Persistent slow coronary flow, prior to re-endothelialization, which is exposure of the blood to tissue factor or stent itself, and cessation of antiplatelets. So this is the mechanisms. This is the mechanism. What are the risk factors? Of course, as we all know, the single most important predictor of early and late stent thrombosis is absence of platelet P2Y2 receptor blocker therapy at the time of the event. I believe this is the reason why we see stent thrombosis, like 90% of the reasons why we see stent thrombosis into the newer stent, second generation stents. The single most important predictor of early and late stent thrombosis is the absence of platelet P2Y2 receptor blocker therapy at the time of the event. Other risk factors, acute coronary syndrome and proximal LAD lesion. We see this with early stent thrombosis. Side branch stenting, diabetes, and end-stage renal disease. We see this for late stent thrombosis. A slide about why do we see more stent thrombosis with acute coronary syndrome, mainly acute myocardial infarction. Patients with acute myocardial infarction are characterized by higher rates of stent-specific adverse events as compared to patients with stable coronary artery disease. This may be partially explained by plaque instability of AMI culprit lesions. Moreover, suboptimal stent sizing and subsequent malopposition represent another important determinant of increased stent-related events in AMI patients. We've all have seen that. A patient comes with a segment elevation MI, the culprit is the LED, and he has a lesion in the circle or the right. So we do the LED, and before discharge, we want to do the other vessel. During the MI, we decide, oh, this is, for example, a 2.5 or 2.7 circ, fine. Then, after 3 days, we're surprised to see that actually the vessel is bigger than what we originally thought during the SC segment elevation MI. This occurs as a consequence of coronary vasoconstriction as well as thrombus presence of the culprit lesion site. Back to the risk factors: incomplete stent expansion, greater stent length, residual plaque burden, and small stent area on intracoronary ultrasound, small vessel caliber, residual thrombus or persistent dissection after stent placement. Other risk factors: inflow or outflow obstruction, subtherapeutic peri-procedure anticoagulation, LV dysfunction, non-ionic contrast media, cocaine use, emergent stent placement, prior brachytherapy. Other risk factors: post-procedure Tamiflu grade less than 3, no aspirin at the time of the procedure, malignancy, coronary artery disease more than 50% or proximal of culprit region, treatment of bifurcation lesions, it's always higher stent thrombosis, multi-vessel disease as shown in the SYNTAC trial. Continuing risk factors: high on treatment, oral antiplatelet therapy, platelet reactivity including polymorphisms in the genes, the use of clopidogrel rather than prasugrel or ticagrelor in patients with ACS. As we all know now, the ACC-AHA guidelines, in acute coronary syndrome, it's a class 1A recommendation to preference to use prasugrel or ticagrelor over Plavix. In ACS, the presence of uncovered stent struts as detected by OCT. Okay? But still, as I alluded before, the single most important factor is the early cessation of P2Y2 inhibitors. Hello. Is there a difference between DES and BMS in stent thrombosis? Both randomized trial and observational study data have demonstrated that the cumulative rate of stent thrombosis is similar for BMS and the first generation DES, Cipher, which are not longer used, or Taxus, at up to 5 years. There have been no randomized trials comparing second generation DES, such as everolimus eluting stent, Xience, or resolute zoteronemus eluting stent, resolute, that were large enough to be sufficiently powered to determine the relative rates of stent thrombosis between BMS and EES or resolute zoteronemus ES. Okay? So, BMS and first generation DS is comparable. The second generation drug-eluting stents and BMS, there were no randomized trial. What about comparison of different DES? Not all types of drug-eluting stents have been directly compared. The evidence suggests that the use of newer generation DES leads to lower rates of stent thrombosis compared to older DES. Most of the data are for the everolimus eluting stent. There is less information available for the resolute. But it's possible they have lower rates than older DES, Potential factors responsible for lower rates of stent thrombosis with newer DES include more biocompatible polymers, newer stent designs with thinner struts, and lower drug dose. Hello. Of course, we all know the management of stent thrombosis. They usually present with acute coronary syndrome, and of course, we have to take them to the cath lab. So just 2 slides about management. In general, the acute management of patients with stent thrombosis is similar to that for other patients with an ACS. Important points include considering the diagnosis in any patient, ACS with prior stent placement and rapid attempt to restore vessel patency. I learned this actually when I was preparing this slide. At the time of coronary angiography, most patients have complete thrombotic occlusion, of course, semiflow. The point that I learned that the culprit region is more common in the LAD artery, 48% in patients with early and late stent thrombosis, whereas the RCA, 38%, is more commonly involved in cases of very late stent thrombosis. I don't know why, but in early and late stent thrombosis, more the LAD, the very late is the RCA. For patients diagnosed with stent thrombosis while on clopidogrel, we suggest switching the patient to prasugrel 10 milligrams daily or ticagrelor 90 twice daily, according to the ACC/AHA guidelines. For patients diagnosed with stent thrombosis who have completed the minimum recommended course of clopidogrel, we suggest starting prasugrel or ticagrelor daily rather than restarting clopidogrel 75. In patients with stent thrombosis, irrespective of whether they were or were not on DAPT at the time of the event, we suggest DAPT for a minimum of 1 year after the event rather than shorter periods of time. I suggest we need to have a session lecture about DAPT, longer or shorter duration. The ultimate duration of DAPT will require continual assessment of the benefits and risks. In summary, stent thrombosis is an uncommon but potentially life-threatening complication of the placement of intracoronary stent. While it can occur at any time after stent placement, the majority of events occur within the first month, irrespective of stent type. Stent thrombosis with BMS or DS has been observed as long as 5 years after stent placement. The presentation is often with MI, usually with stent elevation, ST elevation, or death. The premature cessation of dual antiplatelet therapy is the most important risk factor for stent thrombosis. The cumulative rates of stent thrombosis at 1 year are comparable between BMS and most DES, with the possible exception of everolimus eluting stents. At 2 years, the cumulative rate of stent thrombosis is approximately 1.5 to 2% and similar to both BMS and first generation DS. It's likely that this is lower for everolimus eluting stents. The cumulative long-term risk of stent thrombosis appears comparable among all DS except again a possibility higher risk for paclitaxel and lower risk for ES. Still, the final recommendation data are limited to make inferences regarding the risk of stent thrombosis for resolute zoetronemal stent, but available data suggests the long-term risk is similar for resolute and ES. Thank you for your attention.